There is a story about a shoe salesman in the 1950s. He owned several successful stores. A journalist asked about the key to his success. He responded, 2, not 3.
What does that mean?
He said, if a customer comes into my store, I'll bring her 2 pairs of shoes. She'll try them on, and she might ask to see another pair. So, before I bring the 3rd pair, I would ask which of the 2 pairs she had I could take away. He found when customers had too many choices, they bought none. And when they had a choice of 2, they bought 1.
Genius. So he was basically giving them control and helping them narrow down their choices at the same time.
Exactly.
Too much choice is overwhelming. So keep that in mind as we go through today's content. Welcome to a module on implementing the study protocol and delivering the intervention in pragmatic trials. In this module, we'll explore how to strike the right balance between fidelity and flexibility, making sure the intervention is delivered as intended. We'll look at how to train and support staff across a diverse set of sites. We'll also review monitoring intervention delivery and discuss best practices for documenting any adaptations in a way that's both practical and rigorous. Much of the content will be presented through a case study of the Register Now trial. Implementation can make or break your trial. The key is balance, protecting fidelity by delivering the core elements consistently, while still allowing flexibility so sites can adapt to their own context. Get this wrong, and the risk for failure is high, uptake falters, outcomes blur, and validity suffers. A strong implementation plan starts by mapping each site's workflow. Then, incorporate the intervention into daily tasks. Next, clarify roles. Identify who is responsible for ordering, who delivers the intervention, and who documents it. Small gaps in responsibility can quickly lead to breakdowns. Then we need to equip staff. That means providing training, refresher sessions, and simple job aids that make it easy to deliver the intervention consistently across varying settings. Finally, we set up systems to monitor adherence. This includes checking whether the intervention is being implemented as intended and collecting data to track both fidelity and changes over time. Let's walk through an example of using the Register Now trial as a case study. In 2019, 4,300 Canadians were on the transplant waitlist, and more than 220 died while waiting for an organ donation. The paradox is that 90% of Canadians say they support organ donation, yet around 35% have actually registered. This gap between belief and action leaves many potential donors unregistered. The impact of organ registration can be profound. When a loved one's wishes are clearly documented, families consent to donation about 90% of the time. However, when the registration status is unknown, family consent drops to 50%. This crisis of support versus action underscores the need for innovative approaches to increase registration. For the next few slides, Dr. Alvin Lee discusses how their team developed and implemented their intervention in the Register Now trial.
So, in collaboration with Ontario's organ procurement organization, Trillium Gift of Life Network, we decided to test a new approach to boost organ donor registration in family physician offices. They were initially planning a large-scale initiative across the province, but we thought it would be wise to start small, testing the waters with a few offices before expanding. So why focus on family physician offices? Well, there are a few key reasons. So, around 77% of Canadians see their family doctors at least once a year, which is much more frequent than the every 5-year visit to renew a driver's license. This gives us regular, meaningful contact. Reception staff are routinely checking OHIP cards where donor status is clearly printed. This creates a natural opportunity to encourage registration or verify someone's status. Many patients trust their family doctors for important information, so this setting is ideal for promoting organ donation, and family doctors believe it is within their scope of practice. And while patients are waiting for their appointments, they have a few minutes to spare, which we believed was a perfect window to register for organ and tissue donation. So, taking into account the problem and the potential of family physician office, we created Register Now 1, which was our first trial aimed to increase organ and tissue donor registration in family physician offices. So before I dive into it, I want to briefly discuss how we came about developing the intervention. We used a fairly thorough process. We first did semi-structured interviews with patients to identify barriers and enablers to donor registration. Our semi-structured interview was guided by the theoretical domains framework, which synthesized a range of psychological theory and constructs applicable to behavior change. Some of these constructs include knowledge, emotion, memory, and social influences. So overall, all of our interviewees were supportive of organ and tissue donation, but about half had not registered yet. So, for example, for our interviews, it was revealed that they didn't know the first thing of how to register, or they think they say sign your driver's license, which is not true, by the way. In Ontario, your registration is in your health card, but in the US, your registration status is often on your driver's license. And since there is so much more media from the US, this may be confusing to Canadians. So taking into account some of these quotes, we thought about the mode of delivery we could use. We believed that reception staff could prompt patients and provide them with a pamphlet that addresses these knowledge gaps around organ donation. We'll use an iterative process with the research team to link these behavior change techniques to our identified barriers and enablers from the interview. The benefit of doing this entire exercise is that we are very transparent in the methods we used, and if our trial worked or did not work, it would add to the body of work examining which behavior change techniques worked or did not work. So, because oftentimes you may read about an intervention and it will be something like we educated about organ donation and that's it, which doesn't really help you reproduce the findings. So to summarize our intervention, I'm going to use the tidier description. Our trial was titled Registered Now. As for the why, there is a gap between a positive view and motivation to register and actual registration rates. Family physicians are a novel but underused but likely appropriate setting for promoting donor registration. In terms of materials, we had pamphlets that were addressing barriers, iPads in the waiting rooms. For the reception staff, we had scripts for them for how to check the OHIP card and laminated signposts for the iPad. And for family physicians, we provided them a list of suggestions for how to respond to frequently asked questions that patients may have. In terms of the procedures, reception staff in each practice would check the back of the health card for the donor status. They would make a short pitch and provide the pamphlet and point to the iPad, and then patients will then register on the iPad. And we did this intervention in the waiting rooms of 6 family physician offices in southwestern Ontario. The whole trial itself took about 14 weeks overall, and it was delivered to every patient not registered for organ donation. And we suspected that the duration of the intervention for patients were about 2 to 5 minutes, happening only once.
The Register Now trial was a pragmatic, step-wedge, cluster randomized trial that included 6 family physician offices. Each office began with a 2-week control period, then crossed into the intervention at staggered 2-week intervals until all sites were implementing it. The researchers tailored the intervention to each physician's office by creating personalized pamphlets featuring the practice name and the physician's photo or signature. The tablet placement was adjusted to fit each clinic's waiting room layout, and staff used their discretion in approaching patients depending on how receptive they seemed. In terms of modifications, there were no major protocol changes. Only small adjustments were made, such as repositioning tablets for better visibility and refining how staff handled sensitive conversations based on feedback. To support fidelity, staff training emphasized confidence and self-efficacy, grounded in social cognitive theory. Implementation was monitored through weekly research team check-ins and a simple pamphlet tracking system. In total, 2,250 pamphlets were delivered to clinics, with about 940 actually reaching patients, roughly 7.6% of those eligible. This gap between materials supplied and materials distributed highlights the challenges of ensuring consistent delivery, even with strong monitoring and support in place. There were several barriers and enablers during trial implementation. Staff sometimes felt uncomfortable raising sensitive topics. Clinics faced competing priorities, and many patients were already registered, limiting opportunities for engagement. At the same time, there were clear enablers. Tablets worked as strong visual cues to spark conversations. The trusted family practice setting gave credibility to the message, and staff showed genuine commitment to the cause. From Register Now, several lessons emerged. Family physician offices remain a promising setting, even though results were not statistically significant. The trust and continuity of care in these clinics offer unique advantages for health promotion. A stronger involvement from nurses and physicians can help address sensitive conversations that reception staff found challenging. Next, technology must improve. The registration website proved difficult for some patients, particularly older adults, underscoring the need for more user-friendly tools. Finally, the team learned that timing matters. Busy seasons like flu season or holidays reduce staff capacity for added tasks. Every trial and every intervention will have its own unique set of supporting materials, but there are some common tools that can make implementation smoother across different settings. Quick reference charts give busy staff simple, at-a-glance guidance. Visual reminders, like posters in key areas, keep the protocol visible and top of mind for staff and participants. Frequently asked questions provide ready answers to the most common questions staff might face. Step-by-step guides offer clear, detailed instructions to promote consistent delivery, regardless of who's on shift. Beyond these common tools, you might also consider job aids like pocket cards or short e-learning modules for refreshers. However, remember that too many options can be overwhelming. The goal is to keep materials practical, clear, and easy for staff to use and share. We can't stress enough the difference between adaptation versus drift. Adaptation is a good thing. It means making intentional changes that help the intervention fit into local context, while still preserving its core elements. Drift, on the other hand, is problematic. It happens when unintended changes that build up, eroding the essential components of the intervention until its impact is compromised. That's why you should have guardrails and be clear about which core components cannot change and which peripheral elements can be adapted to suit the setting. With any change, document the necessary items so that adaptations are clear and traceable. Start with what changed, the specific modification to the intervention. Document when it was made and the timeline of its implementation. Note by whom, the decision makers or teams involved. And always include why. Systematic documentation strengthens transparency, supports analysis, and guides future implementation. Most importantly, it helps us distinguish between an intervention that didn't work and one that failed because of poor implementation. As we close, remember that your implementation starts with early planning with your local partners, then providing strong support through training and monitoring. Keep in mind that offering too many choices, tools, and materials during training can be overwhelming for staff and participants. The key is to keep materials simple, clear, and consistent. Maintain the right balance between fidelity and flexibility, and always document adaptation systematically. These practices help ensure that interventions are delivered as intended, neither diluted by drift nor lost in complexity. Thank you for following along. If you found this module helpful, don't forget to like, subscribe, and hit the bell icon so you don't miss future content.